Now we have our second of our presenters, Joshua Tepper. So it's my honour to introduce Joshua, Dr. Joshua Tepper. Naturally, when one goes to introduce a keynote speaker, one does some background investigations, and I did. And I found that Joshua has numerous qualifications as per the conference program. So I was just blown away by these EMBA, MPH, CFPC, MD and BA. I knew what a few of them were, and I had to look up the rest.
Me too.
Yeah, you too. I also discovered that his many previous, he has had many previous and current roles. Currently, so we know that he is a family physician and president and CEO of Health Quality Ontario, but he's had several other roles prior to these. So what does that tell us? It tells us that he has tremendous and extensive capabilities across several organisations and on many fronts, including his social values and perspectives, which have been and remain at the forefront of his endeavours. Joshua is internationally regarded and he's well sought after for eminent conferences such as this. Recently travelled down under, and I know you've been there a few times, or certainly been there before that as well. That was to Australia. But the roles and qualifications do not do justice to the influence that Joshua can and does have over health professionals. Last year, MidCentral District Health Board and the Central PHO supported a masterclass trip to Canada and Scotland. Now, I was fortunate enough to be on the second part of that. I unfortunately didn't get to attend the Canadian leg, where our participants met with Joshua, and they spoke very highly of his vision and his passion. And clearly, Joshua, your influence still remains with those participants now. So I've subsequently listened to Joshua. I've seen him present on the interweb thing. You know, we've just got it in town, and so I watched some of that. And I found it engaging and engrossing, and I'm sure you will too. Dr. Joshua Tepper.
Good morning, and thank you so much for having me here. It is a huge honor to meet the masterclass, many of whom are here today I've reconnected with, and then to have that lead to a chance to be part of this really eminent conference, as you pointed out. I apologize for not being able to bring welcoming greetings in your language. On a good day, I struggle with English. So, really nice to be able to speak on a topic that I care deeply about. When I was hired for my job about 16 months ago, I guess I was hired a little longer, been in the job about 16 months. In the interview process, they said, what is one legacy that you'd like to leave? So wow, they're already getting me out the door. And I said, I would like to think that when I left this organization, that we have embedded the value of the patient and the patient experience in the public into the quality agenda for the province. And I believe that because it is how we're going to transform the health business. So shortly after I took on the job, literally in the first week, I met with an organization called Patients Canada. And the executive director came and he said, I should never begin a talk on quality without talking about the voice and the experience of the patient. And so I want to tell you about a patient's story. This is a young gentleman named Greg Price. For those of you who know a bit about Canada, the cowboy hat tells you he's not from Ontario, he's from out west in Alberta. And he's dead. I want to tell you why. So he went in to see his family doctor. And the family doctor actually noticed, he's a young, healthy guy, and barely in his 30s, and noticed in a very thorough exam, and noticed he has small sort of mass or node or something on one of the testicles. And he actually did the right thing, he noted it in the chart. And the days go by, and the weeks go by, and the months go by, and Greg goes in for another reason. Family doctor very thoughtfully makes note of the chart, re-examines him, the same spot is there, maybe a little bit larger. So he does what we do hundreds and thousands of times a day across Ontario and practically across New Zealand as primary care doctors. We take out a piece of paper and we fill out a referral and we send a fax off to the general surgeon. And the days go by and the weeks go by and the months go by, and Greg doesn't hear anything, but he does hear develop some back pain. So he can't get in to see his family doctor, so he goes to a walk-in clinic. And the walk-in clinic doctor actually examines it quite thoroughly and notices an abdominal mass. He's sent off for an ultrasound. It takes a while for it to negotiate through the system a little bit to get back to his normal family doctor. It's concerning, there's something in the abdomen. So urgent CT is organized, but as probably is the case here actually in many parts of New Zealand, family-based, community-based family doctors don't have access to academic health science center urgent CAT scans. That's true in Ontario, it's true in many parts of the world. And so it takes a while to sort this out, but eventually they get an urgent CAT scan and it's deeply concerning. So he quickly, once again, fills out a piece of paper, faxes it off to a urologist. The days go by, no word, but now Greg is attuned to this and we know this one is blind. And he calls the family doctor back and he says, I haven't heard anything, like you told me this was important. The family doctor quickly checks. It turns out this urologist is on vacation for 3 weeks. That fax is sitting on a fax machine in an empty office. Very quickly, another fax is sent off to another urologist. It's picked up. Literally within days, he's rushed to surgery. The surgery, he exits surgery, he actually exits the hospital in a very short time. Short number of days later, he develops acute shortness of breath. He's brought by the paramedic team to the emergency room. Shortly after that, his shortness of breath gets much worse. He goes into a full pulmonary cardiac arrest. He stops breathing and starts up. He dies. Despite resuscitation efforts are unsuccessful, and he remains dead. So here's a young man who, before hitting the peak of his life, is dead from something that nobody in North America, in fact, any developed country should die of, which is metastatic testicular cancer. I mean, people can have testicular cancer, go on and win bike races, admittedly with a bit of help. And yet, the amazing thing is, Greg had great quality care. He did. Let me break it down for you. So he went and saw his family doctor as a young, healthy guy and had a very subtle clinical finding identified. Frankly, there's a lot of primary care doctors. I'm not sure how many of us would automatically do such a thorough, careful exam and a young, healthy guy dropping in for just a routine physical. And he marks it in the chart and he sends an appropriate referral. And then when he comes back, he double backs on the chart, redoes the exam, finds it all, and does the appropriate, sets it all up. And then he goes and sees a walk-in doctor. And it would have been pretty easy for this walk-in doctor to go, 30-year-old, you're playing some football, doing some wrestling with your friends, lifting some weight, take 2 aspirin. If it's not better in 2 or 3 weeks, see your normal family doctor, right? Bend over, a little bit of soreness, some muscle pain. It would have been super easy, right? But he doesn't. He does a very thorough, thoughtful exam, full history of physical, and detects, which is possibly hard to do, a subtle abdominal mass on a physical exam. And then the ultrasound is well done, technologically well done, well read by the radiologist. And then the CAT scan is done with the right dose of radiation, the right scanning, the right technician, and the radiologists do a great job picking up all the lymph nodes and everything in the mass. And then that surgical team does a great job, and I'm sure if we read the operative note, it will say things like sponge count complete, minimal blood loss, all biopsies sent to pathology, proper staging according to standards and best practices, excellent care, and in fact, leaves hospital in a short time. When that paramedic team comes and picks him up from his home and carries him in, IV lines are started, oxygen is started, everything's done, good quality care. And when he dies and he has a full resuscitation effort, it is well done. CPR per protocol, drugs and tubes per protocol, everything done. And a young, healthy man like this, had been an emergency room doctor myself, we would have spent a lot of time trying to resuscitate a young, healthy man. And all according to protocol. And so what's interesting is, in fact, what we see is excellent parts of our healthcare system, but a failure of the system to be a system. And what I actually believe is that the more we empower patients and the more we allow them to be part of their care journey, the fewer cases like this we will see. That's my tenet to you, and I'm going to show you in the next little while why I believe this to be the case. So patient engagement is pervasive. It's everywhere. As our health minister in Ontario, it's a big place. We've got about 14 million people, $40 billion healthcare budget, 48 cents of every dollar goes to healthcare. We've got millions and millions of people. And as our health minister said very recently, we are moving away from a time when we used to provide care for patients to a time when we provide care with patients. And what I want to spend a couple minutes doing now is I want you to start thinking about this in 3 different circles. So I've been on a plane for a long time, so I pace, it's my exercise for the day. And I think more than this is too much for me, but I can do this. So I want to tell you 3 stories. I want to tell you 3 different stories. So the first story was actually from the New York Times newspaper. It's a very global newspaper. And it was written by an internist called Daniel Offrey, who writes periodically. She tells this very interesting story. She walks into a room, and as soon as she walks in, she can tell the patient's angry. She just reads it, right? Body language, everything else. And sure enough, she says, "Nice to see you," and the patient says, "Well, actually, it's not nice to see you. I'm not even sure I was going to come back today." Whoa, it's not good. So quickly scans the chart, realizes she's only seen this patient once before. She's quickly scanning the note, trying to make eye contact. And the patient says, "You know, I used to have a resident look after me, and everybody said I was so lucky to have a staff doctor now, but I miss my resident." So that's story number 1. Story number 2 is actually a friend of mine. So he gets married. Very nice. I was there. It was actually a lovely wedding. And remarkably short time after, being an efficient gentleman, he calls me. He said, "I have some amazing news. We're expecting." I said, "That's amazing." He said, "I'm not allowed to drink in the house anymore for 9 months. Can we go out for a beer?" I said, "Yeah, sure, I'd love to." So we go for a beer, and he's like super excited and stuff. So we're chatting, and it's really, really lovely. And he says, "You know, my wife, she's so excited, but she called her primary care provider, her family doctor, and they didn't call her back. And then called again the next day, no answer, and now she's just like ready to leave this family practice. Like she's just done with them, done." And then, you know, like, and he looks at me, he's like, "Your family, like, isn't this crazy? Like, isn't she just a bit hormonal already? Isn't it like 9 months of this?" Story number 2. Story number 3. There's a very sad case in Ontario Hospital where a young man admitted for mental illness kills himself while admitted to this hospital in the Greater Toronto area. And what evolves very quickly over time is a very public, on the front page of the newspaper, fight between the bereaved parents who say, "I want to know what happened." And the hospital says, "Listen, we've given you a bunch of data, but like in the interest of quality improvement, there's some things you can't know under legislation because it's how we create a safe environment to debrief. But everything you need to know, everything that you should know, we've given you. All the facts are there." They say, "No, you've had meetings about this. We want the minutes from the meetings. We want to come into those meetings. We want to know what was said in that meeting when you had your debrief." They said, "Well, you have all the facts." They said, No. We want to know more." They said, "No, this is where our providers have a chance to safely talk about how to make sure this doesn't happen again, improve the quality of care, and talk in a constructive way about this." This was playing on the front page of the paper. And the health minister calls my board chair and says, "I want you to look at this issue and understand if the legislation that is at the crux of this dynamic is appropriately worded, or if it's being abused by the hospital or misinterpreted by the family." 3 scenarios. Now the fact is, we're very good at this bottom scenario. This patient-provider thing, where Danielle walks into this room, and patient, we're actually, how many people are healthcare providers? Like 30%. I was going to say 30% no matter what. But it was about 25 to 30%. You know, we're actually really good at this, right? We're good at creating a therapeutic relationship. We're good at understanding how to deal with breaks in the therapeutic relationship. We're good at being patient-centered. We actually know how to do this patient engagement really well. And so I don't worry about this. And when we talk about patient engagement, it's really much less about this one-on-one thing. And sure enough, in this story, she does all the right things. She says to this patient, she says, "I've only seen you once. Clearly I did something wrong in that encounter. I'm glad you at least came back today. If you never come back again, could you at least tell me what I did wrong, so I'll try to not do it again with another patient. And there's a small defrosting, and the story plays out accordingly. I'll tell you what happened. Yeah, it was like, now what happened? So basically she says, you know what, you took a history, you talked to me for 15 minutes, and then you handed me a script. You never examined me. You never touched me. You've never examined me. Like, I don't even know how you knew to give me the right prescription. She said, you know, you're right, my notes say that. It's not my normal practice. I really apologize. I would like to examine you properly today. If you don't come back, fair enough, but at least let me do my job the way I should have done it. And so they have this very awkward sort of clinical exam, and it works out, and they repair the relationship. So then back to my friend, Beth, who, the first thing I say is, never call your wife hormonal. Not now, not in the next 9 months, not in the next 90 years. Right, check. And then, so that was good. We moved on to our second beer. And I said, you know, the second thing, buddy, is it doesn't actually matter whether you think it's crazy that she wants to call back in 24 hours or 48 hours. It's what she expects. It's about her expectation as a patient in that healthcare system. And then what occurred to me as I drove home is, this could be happening in my practice, and I would never know. Why? Because it's not a provider-patient relationship. That family physician, who's her doctor, never knew that she called 2 times in 2 days and didn't get a call back. In fact, there's no opportunity for her as a patient to write in and make this concern known. And so what we don't have is a system structure in order to actually capture the patient experience, understand what the expectations are, and have some way of doing it. We don't, we're not bad at capturing individual feedback between provider and patient, but we don't capture system feedback. And this wasn't a provider issue. It wasn't like she met the family doctor and he'd done something wrong around the pregnancy. It was actually the structure of that health organization was providing what the patient felt was inappropriate response times to access. And we don't capture that effectively. And then the third one was when the minister called and my board chair turned around and said, I'm happy to do this on one condition. I co-lead the review process with a patient or a caregiver. Because if we're going to make changes or voice opinions and make recommendations about how to improve the healthcare system, it's not going to be me as a doctor alone. It's going to be together with a patient and a caregiver. And that's what they did. They identified a caregiver, they co-led a panel, and together they submitted a report to the Minister of Health. So what I want to think about is that we tend too much to focus on this bottom square, the patient-provider, but really what patient and consumer engagement about is these upper 2 squares as well. I love this quote from Victor Hugo, the famous philosopher, writer, poet. There's nothing more powerful than an idea whose time has come, and I really believe this is the case with consumer engagement. And so what are we seeing? What we're seeing, actually, is a very careful trajectory over time. And this is a combination of a TED Talk from me, Patient Dave, and for the sort of medical folks in the crowd who want some references, a New England Journal article. And what we sort of see is a time period, a shift from benevolent paternalism, from sort of trust me, I'm the doctor, trust me, I'm the nurse, to actually sort of patient-centered. Now we just, at least let's talk about Mrs. Smith, what are Mrs. Smith's expectations? I'll decide them for Mrs. Smith, but let's at least acknowledge this is what Mrs. Smith's wants are, needs are, we're very patient-centered. And now what we're actually seeing is the birth of patient engagement, in a few cases patient co-design, and increasingly patient-driven. And we're very much on this trajectory of patient engaged, patient co-design, and even patient-driven. And this is sort of a very famous patient engagement piece of literature and chart. So inform, advise, collaborate, and empower. And again, we're moving very much from this inform somebody to advising them to much more this collaborate and empowerment. So 2 different ways or different frameworks of thinking about it. And this is very much where I think we are in the healthcare system. And some parts are farther ahead of this curve than others. But all of us should be on a trajectory. So the real question is, why is this happening? And I've done a lot of things. I'm going to talk a lot about why it's happening, but I actually found a very interesting answer from the sector outside of healthcare. So when I did my MBA, one of the most interesting things was realizing that instead of growing up in a healthcare system where I thought we just had all the answers and the other sectors, catch up. What I actually found is other sectors were way ahead of healthcare. And I actually found that we can learn a lot from places not in healthcare. And so this article, which I'm referencing, is actually all about technology companies. It is about Apple, IBM, Twitter, Airbnb, Foursquare. It's all about technology companies. But when I read it, I thought healthcare. So here's what they say, and I apologize, there's a lot of text on this, it breaks every rule of PowerPoint or something. So they talk about old power. Old power works like a currency. It is held by few, once gained it is jealously guarded, and the powerful have a substantial store to spend. It is closed, it is inaccessible, and is leader-driven. Healthcare, anyone? New power. New power operates differently. It's like a current. It is open, participatory, and peer-driven. The goal with new power is not to hoard it, but to channel it. And this is what's happening with consumer-driven healthcare. We're moving into new power. And again, it's sort of fascinating. There's this great chart in this article all about technology companies, which is just like the chart I showed you a few minutes ago about healthcare. Moving from consuming into sharing, but ultimately to co-owning. And how we're seeing a shift in other sectors along this same trajectory. And this great final quote, we all have an inalienable right to participate. Today, people increasingly expect to actively shape or create many aspects of their lives. And that's not just in technology. That is first and foremost, it's something that matters to people more than anything else. Their health and their health of their loved ones. We are seeing a shift to new power, and that new power is what is driving consumer-driven healthcare. So how is this happening? I'm going to hit you with a bunch of examples about how this is actually playing out. How new power is being executed each day in the healthcare system. So first of all, this is an app. It's an app you download for free on any device that you have. Android, Apple, whatever you have. And this app will tell you down to the minute what the wait times are for every emergency room in the largest cities in Alberta. And if you're not sure that you like the wait times, it will tell you where all the urgent care and walk-in centers are, when they're open, when they're closed. You can click on it, and it'll open up a map and give you directions right there on your phone. So imagine the power and the access to your healthcare system that you never had before. And I talk to patients all the time, and I say, you really need to go to the emergency room. I look after almost only homeless men. HIV, hepatitis C, that's my population. And it is really hard to get them to go to the emergency room because they often feel they are all homeless. They often feel poorly treated by security, poorly treated by the staff. But I just imagine myself, if I could show them that the wait is only 2 hours, and I can send a counselor over with them to wait, I might get them to where they need to have care because they're having access to information about their healthcare system. A free app, every emergency room, down to the minute. Now, I'll be clear, there's some controversy in the literature about doing these types of things. But patients, boy. So then there's my chart, my health, access to information. When I started off in training, everybody's information was held in a bunch of paper right where I could hold it. I could take it home with me at night, although I wasn't supposed to, it wasn't allowed, but it was locked away in my file cabinet. Now people have access from around the world. And the hospital I used to work at, my chart, patients have access, they can give their family doctors and their family members access. So let me give you a story. We're a big cancer center at Sunnybrook. And a woman came in with very complicated abdominal cancer, colon cancer, had multiple surgeries, multiple treatments, radiation, everything else. Finally got the all clear. To celebrate, she was in some remission, everything was fine. She booked a beautiful getaway vacation down to a tropical place, hundreds of kilometers away. Literally, as the plane takes off, she starts to develop abdominal pain. And by the time she lands, she is in extreme pain and extreme distress. And they go in and they rush her straight from the airport to the hospital, to the local hospital there. And the doctor says you have a bowel obstruction, which is often due to adhesions after surgery. So not unexpected, but a really unfortunate thing. And he said, we're going to have to operate, but I have to tell you, you've had so many operations, so much scar tissue. I don't know exactly what was done. There's some risk. She said, well, here's my passcode. Just access my chart. You have the internet, right? I hear you even just had it here. I'm so excited. I'm going to use that after my talk. That interweb thing. So the doctor goes on and has full access to the recent CAT scans, the full operative notes, and has a full insight to the operative care and the post-surgical care of this patient, hundreds of kilometers away, and goes into that operation with a whole new sense of confidence and knowledge, or confidence that comes from knowledge. Why? Because the patient controls the information. If that doctor said, oh, well, let me call back to Canada at 3 in the morning and try to find your record and get permission and get them back, no, never would have happened. But for the patient to say, it's my chart, it's my information, here's the access, that changed possibly her surgical outcome, certainly allowed for a better opportunity. So here's another. Not only do people have more access to their own information, not only do people have more access to the healthcare system, people know more about their healthcare. So here's a free website of plain language, grade 8 level, evidence-based encyclopedia of common healthcare conditions. It's on the Ministry of British Columbia's website. They pay for it. Anybody in the world can use it. Anybody in the world can use it. And allergies, it was I picked something here at the beginning, allergic rhinitis, and it just talks about it in plain language. So now people actually understand more about it. There's a guy named Mike Evans. He turns out these YouTube videos of about 8 minutes in length. They're completely accessible, completely plain language. They're funny as get out. They're thoughtfully done, completely evidence-based. Over 100 million hits on his YouTube channel. 8-minute segments. He calls it the new medical school. He calls it the medical school for the masses. Because people go on and they learn about fatigue and chemotherapy. They learn about back pain. They learn about appropriate test tubes. They learn about not to do x-rays for low back pain. They learn about exercise and diabetes and osteoarthritis in 8-minute increments that are so simple and so accessible. Tens of millions of people. So people know more about their health conditions. They have access to their own health information. They have access to the chart. And now they have a brand new way of accessing. So how many people have heard of HealthTap? HealthTap is a way that people simply text messages to fully registered qualified conditions. This says 50,000 doctors. Actually went on last night. It's up to 68,000 doctors. All licensed, all qualified. And you text in for free a question. So here's an example. I had a bruise under my right eye and now it turned red. How do I get rid of it? And you get an answer back within literally hours for free. And if you want a deeper consultation, then you pay like $5. And then they actually put feeds out to you. They will provide ongoing support around areas of interest if you have diabetes or another chronic disease. And you never see anybody do. And they do a lot of encrypted video con recording through your phone. My patients are always like, can I actually come in? Can I FaceTime you? I had a patient actually find me on LinkedIn to make an appointment the other day. Good story. I actually had the slide. I take it there if you want. And this is what I always like to tell the medical students when I teach them. I said, just remember, there's no procedure you can offer a patient that by the time they see you, they won't have had a chance to watch on YouTube 30 different ways, 50 different times. It's true. Pap smears, C-sections, shoulder reductions, cancer surgery, have it being intubated, having a breathing tube put down your throat, starting an IV line, you name it, hip fractures, dislocated hips, dislocated shoulders, it's all on YouTube, and not once or twice, but 30 or 40 different ways. And it's happening. I see patients in the emergency, I say, listen, you've broken your hip, I'm really sorry, orthopedics will see you in the morning. I'll go about half an hour later to check on their pain control. Say, how are you doing? They got their iPad. They're like, so which break is mine? Right? They log in, free Wi-Fi, right? Just like this convention center. Hip fracture, Google Images, right? And there's different types of ways of breaking your hip. There's lots of different ways. And they say, this is a horrible one. This one's a good one. Is one a good one or a bad one, Doc? Which one's mine? Right? It's a completely different way of accessing care, engaging in care, participating in care. RateMD.com. I always remind medical students, long before they meet you for the first time, they can go online and see what every other patient you've ever liked thinks about you. People are like, oh, RateMD, it's this rogue thing started by angry patients. And like, okay, that's interesting. Well, hey, there's nothing wrong with that. Stop having angry patients. Figure out how to have fewer angry patients. Seriously, what are you doing to decrease the frustration levels of your patients? Have the courage to go online and read about the comment and figure out what you can do better. So here's a hospital that actually believes that. They said, we're not going to leave it to the patients here, we're going to do it with the patients. Not do it for them, not have them do it to us, but with them. So every patient who goes to Utah, the medical center here, University of Utah Healthcare, gets an email survey with 12 questions. And then the hospital actually puts up every single comment and every single rating by doctor. Short, and they say they post 99.54%. The only ones that remove are racist, hateful, inappropriate type comments, anti-Semitic, whatever. So here's Dr. Gordon Smith. He has 4.7 out of 5. He has 64 patient ratings and 53 explicit, unedited patient comments. So if I'm a family doctor, I say, hey, good news, I'm sending you off to see Dr. Smith. They're like, is that good news? I don't know, let's find out. Is he just a golf buddy? Do you just go to medical school with him? Right, you just, guys at the same golf club. Why are you picking Dr. Smith? What do his patients think? I don't care what you think. Tell me what his patients think of him. So let's go on and find out together right now. Right? Every doctor who works there. So this is Twitter. It's a Twitter feed from a large academic health science center who I used to work for. This is the Vice President of Education there. So here we go. I appreciate you can't read this at the back. I'll read it to you. For you. With you. We'll do it together. Not for you, it's with you. All right. So here I am, keeping my dad comfortable at Sunnybrook Health Science Center. Welcome. Let us know if there's any information we can help you with while your dad is here. Thank you. Actually, there is a question. Can you tell me how to get a parking pass and if I can do it online? Of course, parking pass is here. Click this link, or call them at 416 blah blah blah, or drop into this office in the morning. Right? Common issue that frustrates patients around the globe, especially in large urban settings, about how do you get and pay for parking. And here it's totally solved, all without anybody having to be sort of confronted or bothered, the patient leaving their loved one to sort of wander around the hospital where their loved one's in pain or waiting or whatever, right? Thank you. I have to say I'm pretty impressed with the Twitter response. Your dad is taking good care, your hospital is taking good care of my dad. All right, this person. Well, visiting hours are over and I'm still here. Shh, don't tell anyone. I'm at D-Wing, Sunnybrook. Dude, it's the introvert. Watch out, here we go. Watch out, dude. Sunnybrook is pretty savvy and social. They tweet at me when I was there and I didn't even mention them. They're great here at Sunnybrook. I never got a reply and they mentioned one of our competing offers, but they're all on social media and connections here, right? All very positive, but again, real presence, and this is happening in real time, right? Potentially thousands of people are seeing this interaction. What does that say about the healthcare? What is their expectations? Well, it's not all good news, is it? This is not a great advert for the Canadian Health Service. ER waiting times at Sunnybrook. Who knows who this person is? Who knows how many followers they have? Who knows how broadly and quickly this will be rebroadcast and rebroadcast? We know on Twitter that you can reach millions of people in 8 hours. Right? This is not good. Boom, we're on it. We hear you. Waiting is never easy. Please send us a direct message if you'd like to chat more. Boom, direct engagement. Take the conversation offline to a direct message, and let's have a long conversation because we care. Historically, they would just go home and start telling everybody they knew what a great, horrible experience they had. Wow, very impressed that you took the time to respond. Medical care has been excellent. All we need is a better award. Gets worse or better. Had a first terrible experience with a doctor at Sunnybrook. Refused to allow him to treat my dad. So think about it. We're a trauma cancer center. The people you bring in to see us are really, really sick. So if you're at the point of thinking that you don't even want the doctor to see you, how upset must you be? And historically, you would just leave, right? Maybe you'd find the time to write up or type up a letter and try to go on and figure out who to mail it to, or you'd wander around the hospital looking for the Office of Patient Complaints or the Office of Patient Experiences, we euphemistically call it. Right? You would know how to do it. This person's just putting it out to the world. But we're not. We hear your frustration. Would you consider sharing your thoughts right here? Click right here. Tell us right now. Take 5 minutes when you're as angry as you can possibly be to tell us what's going wrong. Completely different from how we used to deal with patients and their experience, right? And there's clearly something so upsetting, we actually send somebody down in person to talk to them. We actually send a person down, right there, boom, somebody get on it. The Department of Patient Experience is so fabulous and so impressed, I'm going to volunteer. That's so wonderful, glad they could help, glad he'll be helping back, right? Consumer engagement, caregiver engagement, family engagement, a completely different way of working with you. And the doctor, the nurse, the physiotherapist, the social worker, what role did they play in any of these interactions? None. It's our IT department. It's the new healthcare system. I always like to tell people the most important part of our new healthcare team member is going to be the ITIM person. Because what's going to happen is people are going to come in with their Apple Watches and their Fitbits and their remote blood pressure cuffs that they've carefully been monitoring home and their glucose things that they've been taking 6 months worth of data on. And I'm going to ask something stupid. I'm going to say, can I take your blood pressure? And you're going to, you want to take my blood pressure? I've been taking my blood pressure for 6 months. Here it is. And you're like, how do I connect 6 months of really important data to my computer? The most important person on my healthcare team is going to be the IT person who can connect the Fitbit and the Apple Watch into my EMR. Because there's no use me taking one blood pressure when this very thoughtful, careful, diligent patient has been taking their blood pressure twice a day, 4 times a week for the last 6 months since I last saw them, or their blood sugar 2 to 3 times a day. And I need to do it once in the office and say, now I know what to do. So the patient voice, it's not just on Twitter, it's on YouTube.
So the doctors don't let you sleep at all. Like, if you think you're going to get sleep, then you're crazy. Because they come in at 6 in the morning, and they don't all come together. There's a med student first, most of the time, and then there's another one, and then there's another one, and then there are residents, and then there's the actual doctor, who's the actual important one, and then my other doctor, my rheumatologist, he comes in at noon, like a normal person on his lunch break, and he actually cares about me, so he lets me sleep. But then the other ones are just like, oh, no, I don't care, like, do you need sleep to heal? No, I don't think so. Like, that's crazy. Like, who needs sleep? That's not important. So they come in at whatever time, at 6 in the morning, and I am here, and I need sleep. I need to be awake, I need to be happy, and I've tried to tell them that I give better answers, and I will talk to you more, I will participate more if I'm not laying in bed like, what did you say to me? Are you talking to me? I'm asleep. I'm sorry. Yeah, so that's not going to work if you're not getting me engaged and talking to you. Then that's how people work together and do things, because they talk. And if they don't talk, then it's bad. It's just not good. It's not good. And it really annoys me too when they ignore you and they try to talk to your parents. Like, I am 15 years old. I know that it's not that old, but at least I should have some say in what I want being done to me. Like, I am the patient and I need to be heard. Like, I am the patient. It's going to end up happening to me anyway. So if you try to leave the room to protect me from whatever, it doesn't work. I would like to hear what you're about to do to me. If you're about to poke me with a freaking needle, tell me. If you're about to cut off my arm, tell me. I need to know.
15 years old. 3 things that I like about this video. The first is it turned out I should have been a rheumatologist. That's worked on my lunch time. There's once a rheumatologist, he says, no, it's because I also work on my lunch hour. I don't get one. But anyway, that's like, all right, fair enough. The first one rheumatology's got it easy. So here's the thing, she's 15 years old, she's on a chronic medical condition. She's going to be in and out of hospitals for the rest of her life. In 2 minutes and 41 seconds, she defines what quality of care means for her. And we put her entire care team in a room together in a nice conference place like this for 3 days. I'll bet you we wouldn't hit it. Like all the subspecialty physiotherapists, the subspecialty pharmacologists, the nurses, everything, I bet you they wouldn't hit it as cleanly as she has it. Quality for her. The number of people who examine it who's not needed for the actual help. the number of hours of uninterrupted sleep unless medically necessary, fully informed consent to the procedures that I'm going to have in my presence. 3 leading things that mean quality to her as she will spend her life in and out of hospitals. I don't think there's a pediatric acute care center in the country that hits those 3. But she tells you in 3 minutes, 2 minutes and 41 seconds, what does quality mean for her as a patient. She hammers. And here's the other amazing thing about this. How did I find out about this video? How did I find this video? She's not my patient. She's not even Canadian. I don't hold that against her. I found her on YouTube. I have mail. Found her on YouTube. I'm going to have a lot of mail. Hold on 1 second. I got it off Twitter from her mother. Her mother tweeted this out, and I picked it up. But here's the interesting thing. A few months later, I actually saw a reference in the Harvard Business Review. And then I saw it in Forbes magazine. And then I actually saw it on page 82 of the Wall Street Journal. And then there's something called the British Medical Journal. It is super prestigious. I will never get published there, not even better. Right? Another patient, David Brokenhart, wrote an article about this patient and got it published in the BMJ Quality and Safety issue. So think about new power. One patient taking a YouTube video of another patient and publishing it into one of the most powerful and historic traditional medical journals. That's new power. It's a different way of patient engagement. It's a different way of connecting. We're at wait time. So not only just don't have information, we're actually going to start giving you control and choice. So you can roll over any part of the body. You need a shoulder replacement, you need some heart surgery, you need some lung stuff, you're going to get some carpal tunnel, some knee replacement, some ankle surgery, and you're told you need to do. Well, let's figure out how much wait times you have based on where you want to go. Let's give you some choice and some information. So you can actually go online and figure out where in the province have the greatest and shortest wait time. Now, I actually think there's some language issues and some statistical issues that could be worked on to make this even more accessible. But boy, is it starting to break down and change the type of information. Because again, usually how does this get picked? I pick it, right? I decide I'm going to refer to you, or you, or you. And then you pick up the referral and you decide when you're going to see the patient. And then we call you and we let you know. This is starting to change, and if you really want to change it, go to the UK. Choose and book. So here, what happens in the UK in choose and book is actually the referral. I started this, I guess, you suggested probably time for a hip replacement, but you actually have input into where, how, and when you go to see the surgeon. This is now actual empowerment. This is actually giving power over in all the traditional things. You get to pick the who, the where, and the when. This is unbelievable empowerment. And then they don't really just need the healthcare system because they have each other now. And so how many people know patientslikeme.com? So patientslikeme.com was a website started by the bereaved brother of somebody who lost a loved one to ALS. And what he had found is as a patient suffered with this terrible disease, there was very little information about it. And the physicians and the nurses and the healthcare team really could only help him so much. And when you realize it's a rare disease, fortunately, it's a horrible disease, fortunately a rare disease. And so what he actually said is, there's got to be other people out here with the same question and with some of the answers. So he started this patientslikeme.com. And what patients do is they upload all their healthcare information. What medications, what diagnostic imaging, what tests, what trial, the side effects, what's happening, what they found. They upload all this information. They have over 250,000 people. They've got 2,000 plus diseases, and they have more than 25 million data points. There's so much data on here that they're actually crowdsourcing peer-reviewed journals. It's unheard of. But the data is that detailed, and that's right, in peer-reviewed journals. Over 16 peer-reviewed articles so far. My Therapy, MidCentral, these are places where patients go on and they link with literally thousands, hundreds of thousands, in some cases, of people who are having the same experiences, the same disease. And sometimes I just troll some of them. Remember, they talk about which glucometers work best, which test strips work best, what are these very little known side effects from medications. because people end up on 3 rare medications and suddenly things pop out. And the odds of me as a family doctor, even a specialist, figuring that out is low. You start putting thousands of people together, these things start to pop out. And who patientslikeme.com, not a single dollar of industry funding, not a single health professional involved. All patients and caregivers and family members. So to be super clear, it's really actually hard. I want to, I don't want to, this is all fun, there's apps, there's Twitter, all I need is YouTube. It's actually really hard to do patient engagement, consumer engagement. So first of all, we don't even sometimes use a common language. When we have a language, we don't use it in a common way. Some people talk about patient engagement, some people talk about patient experience, some people talk about patient satisfaction, some people talk about the measurement of that experience, some people are talking about the actual active participation, somebody wants to call it a patient advisory or patient participation, some people like patient participation. I say patient, and a lot of us in Canada say patient, you guys use consumer. So the language is all over the place, and the meanings of the language are all over the place, and that makes it hard. And then there's the classic thing, is aren't we all patients? I talk about this in my organization. Somebody says, no, I had cancer 2 years ago. I'm a patient. Or I look after, I have an infant who had some horrible thing, and I can be a caregiver, and I can be that voice. But the problem is trying to differentiate when we come into a room with our consumer hat on, and when we come into the room with our sort of healthcare hat on. And so, yeah, I've had healthcare experiences, my family has had healthcare experiences, but I don't kid myself that when I come into a discussion, that the main hat I'm wearing is a family doctor or a CEO hat. And what we need are people around the room whose only hat, predominantly, or their main hat, is the consumer hat. So yes, there's everybody in the room is a patient. Everybody here is a consumer, and all of you know consumers. I get that. But you're also CEOs and clinicians and administrators and leaders. And when you're coming into the room, the perspective you're predominantly bringing, as hard as you might try, the reason you're paid to go to that meeting or asked to go to that meeting is not because you have a loved one at home who has diabetes. It's because you're there because you have health care somewhere in your job title. And that's why you're there. And so you can't be asked to put on those roles. What we need are people who are there for that one purpose. And Ross spoke very eloquently there today. I love traveling with Ross Baker. It's like traveling with a rock star, right? Everybody, Ross Baker. Let me go with Ross Baker. I'm like, I'm friends with Ross Baker. I was at a restaurant last night. I'd like a reservation. I'm here in New Zealand with Ross Baker. I haven't read his journals, but I will. I will. It's like an entourage. Part is an entourage. So engagement, I was at the back because the first speaker had all these Ross, and I was like quickly searching for a Ross Baker quote I could work in, but I couldn't do it. I apologize, Ross. But he's got a killer presentation this afternoon. I've seen parts of it. So engagement versus expertise. How do we do it? There's actually very little evidence about how we engage. There aren't a lot of trials. So people do obvious things. They create committees, patient family advisory committees, right? So that's good. But is it enough? Some people do surveys. Some people do online surveys. Some people do mail surveys. Some people do phone calls. Some people are in focus groups. Do we actually know when to use how many? How big does a patient family advisory committee need to be? Some people, so the problem with the patient family advisory is it puts all the patients over here and you can ignore them. What you actually want are patients on your regular committees. Don't isolate them to the others. So some hospitals don't have a single committee without a family or caregiver on. Not one. Not budget, not capital, not redesign, not strategy, not. They make sure that the family or caregiver on every single committee in a hospital. These are big hospitals. A lot of committees. We do administration well in healthcare. Or if not well, voluminously. So how do we actually don't know? So some people are trying to say, for every 5 patients, you need, for every 10 members of a committee, you need to have 1 patient. So it'd be, 1 plus. So if you have a 15-member panel, you should have at least 2 patients. Like, the people are making up some rules of thumb, but we actually don't really know. And here's the other thing, is like, who's in the room? Who are we engaging with? I often worry that when we engage, it's a lot like the people in this room. Well-educated, solid income, solid jobs, fairly homogeneous in appearance and cultural background with some important exceptions. And I think about my patients, homeless, Aboriginal, HIV positive, heavily addicted to polysubstances, crystal meth, cocaine, heroin. They're not coming to a meeting in a boardroom. There's not time and place to sleep. They're trying to get one meal tonight. Don't ask them to show up for a focus group at 9 a.m. They're withdrawn. Don't ask them to come at 5 o'clock in the evening. They're trying to get to the shelters before the shelters are full. These are actually the patients we need to hear from most. These are the people who can't, we want to engage with patients, engage with the patients who most need to be engaged with. And we don't necessarily reach out. I go into rooms with patient engagement. I look at the patient advisory council. They look a lot like me. I'm very blessed and fortunate in my life. They don't look a lot like the patients I look after. So these are hard things, and I don't know how we do it right. But it's all about new power. It's all about spreading the opportunity. This is a great Helen Davin, somebody I just sort of adore. I have like a Twitter crush on. I think it's a thing. So she talks a lot about new power through her lens. She says, a dominant approach, power through hierarchy, driven by a simple mission and vision, top down, rational argument, leadership driven. She says, now power through shared connection. PatientsLikeMe.com. Tens of thousands of patients sharing a common disease, a common care experience, common drugs, common side effects to drugs. Making sense through emotional connection. How many people laughed, smiled, and even cheered on the inside when they heard that young 15-year-old girl, right? That's an emotional connection. The story of Greg Price is a tragedy in fact. It's an emotional connection that we don't normally think about. Viral, grassroots creativity. One patient writing about another patient had launched themselves into a traditional bastion of medical journalism or medical articles. Ideas, co-creating, changing ideas. This is the new health. This is the new power. So every great movement needs an agitator. I've talked about the new power being driven by technology, by more access, by more knowledge, by more shared experience, by control. But every good movement needs a leader. William Allen White was a very, very famous politician, one of the most famous publishers in America. He was really the voice of the middle America, the middle class America. Every great movement needs an agitator. And so here's three great leaders in the consumer movement. The first is Dave Brokenheart. You got to watch his videos, 17 minutes, E-Patient Dave. You just type in E-Patient Dave. He is a TED Talks. Everything good in life comes into a TED Talks. And it's about 17 minutes. And, this 40 minutes, this is old. Like, he's way up there now. So Dave was the guy who wrote that article about Morgan, Dave Harden. And so how many of you have heard of the Cleveland Clinic? Or sorry, the Mayo Clinic? Or World Clinic? So every year they invite an in-house scholar for 1 year, a great sort of in-house scholar to be a teacher, an advisor. It's a very privileged thing. For the first time ever, they didn't invite a doctor. They didn't invite a healthcare professional. They invited him. He was about 4 months, 5 months into his term. The first ever Mayo Clinic in-house fellow. I think they call him a fellow. He's not a provider. He's a patient. Tremendous leader, tremendous voice. Active on Twitter, active on social media, active in traditional media like the Wall Street Journal, Forbes, Harvard Business Review, and embedding himself right in the bastion of the Mayo Clinic. Amy Gleason, this is the mother I told you of that young 15-year-old. She goes around and gives keynote presentations now on quality, on what it means to be a caregiver and how to involve patients and caregivers. This young woman who we heard about, she actually now goes and is paid at the age of 16 to consult the pediatric hospitals on what quality of care means. She goes and presents to boards. She goes and gives keynotes. She's a leader in how to involve patients. You remember the story of Greg Price, who I opened with. This is his dad, David. David is a farmer. So how did we find out about the story of Greg Price? We found out because after his death, his dad went through his journals and he began to piece together this horrible fractured system that had led to the death of his son. And he could have sued, could have gotten angry, could have ignored it. He could have written angry letters to the editor. He could have just breathed quietly on his own. But instead he went to the Health Quality Council and he said, you have a problem here and I want to help you fix it. I want to get to the bottom of this. I want to know what happened to my son, and I want to be part of it. And that Health Quality Council could have said a couple things. Bad things happen. I'm sorry. for your loss, but thank you for your time. They could have said, we got it, thanks for bringing this, this is really important. We got it, we'll look at it, we're going to look into this, we'll get back to you. But instead what they did is they said, let's do this together. So this farmer, there's nothing disparaging about that, and this Royal College certified specialist who's in the background behind him, did a complete forensic audit of everything that happened in the months and months leading up to his son's death. And then jointly, they wrote a report, unbiased, carefully nuanced, with 17 or 18 careful recommendations to government about how to improve the system. How to make sure that there are no more graves. Co-design, empowerment, patient-driven, caregiver-driven. This is the opportunity. We need the Amy's, the Ashleys, the David Prices of the world, making our healthcare system better. And our challenge is not to see this as a threat, but the most transformative opportunity we've ever faced. Thank you so much for your time. My goal is usually to run the clock right down to tea time, so we'll see how I do.
I think you're 30 seconds early. I don't know how you managed that. Look, I'd just say, I wrote down one word after, or during that, Joshua. It was wow. And I think that would be a sentiment expressed by many. That was such a powerful use of the patient experience and perspective. It really brought me, anyway, to connect with the person. It allowed me to think from a different perspective, and I'm sure that would be the experience, too, of most of the people here today. Really do love that statement you had, for patients, from for patients to with patients. It really is helpful for us. I said at the start, remember there might be some buzzwords, you know those buzzwords like co-design and co-production. Here was a great example of what that could be, what it could look like, and what we have to move from. So once again, Joshua, I say thank you very much on behalf of everyone here.